Yes, sternum. So it's the manubrium of the sternum. So the manubrium is referring to the part of the sternum. You have the manubrium over here, which is the top part of the sternum. So if we move down to number 2, does anyone know what that is? That is the clavicle. Well done. And then number 3, does anyone know? Acromion of the scapula. Well, yeah. So the acromion would be pointing towards here. Since it's pointing down a bit here, it's the scapula. But I completely get where a lot of you are coming from with the acromion. It's just specifically this arrow is down around here. If it was up around here, it would be acromion, but it's just the location. So just be aware when it comes to locations. In exams, usually they would have a standardization effect after the marking. So most people who wrote acromion would still get the mark, but just be aware when you're pointing to the specific area, you need to be somewhere around here for it to be the acromion. And then number 4, does anyone know? Surgical neck of the humerus. Very specific. So very good, actually. Great. Yeah, so that's the humerus, but very good. It is the surgical neck of the humerus. So very well done. So everyone looks like they're starting off at a good place. So my form of teaching anatomy is I prefer cadaveric images over diagrams because it just allows everyone to appreciate what it looks like in real life a lot better. And I like using the same image but in different perspectives because you need to understand what they look like at different perspectives because you will never ever see just in one perspective when you're in theater from a clinical perspective or when you're in cadaver labs, actually learning the material as well. If anyone has any questions as we're going along, please do just write in the chat and then I'll answer at the end, or if it makes more sense as we're going along, I'll answer as we're going along. So in terms of the first part, so here we're going to look at the scapula anteriorly. So looking at the scapula anteriorly, you can see that we have the lateral border, we have the medial border. Now the medial border is the straighter edge, which is almost perpendicular. And the easiest way to remember this is sort of whenever you're doing RESP examinations, for example, I don't know what year a lot of you are in, but when you do percussion and things like that for the posterior chest, you ask the patients to often bend forwards and put their arms across their chest so that their shoulder blades are a bit more pronounced. That line you see is the medial border of the scapula. And then the other side, since it's lateral to the body, that's the lateral border. Now, the superior and inferior angles, they're called superior and inferior to do with their position. So superior just means on top, inferior means below. They're called angles because they effectively form points. So there's a point superiorly and there's a point inferiorly. So that's why they're called angles. In terms of the other labels, so you have angles and you have notches. So the angles form outwards, they're convex, whereas the notches form inwards, they're concave. So you have a suprascapular notch over here, okay? And the reason why you know it's suprascapular is because it's at the top of the scapula. So supra meaning top, and then scapula referring to the scapular bone, and then notch referring to the fact that it is concave. Now the acromion, which a lot of you mentioned when it came to the quick 4 questions that I asked earlier. So as I mentioned, it sort of needs to be pointing to that bony prominence for it to be the acromion. You also have the coracoid process. The coracoid process being this area. So just to see it a little bit better in situ as well, just if we go back to this, here was the acromion, here is the coracoid process. So you can see a little bit better over here. So if we go back to here, and here we have the subscapular fossa. So the subscapular fossa, if you think about it, it's beneath towards the bottom of the scapula, and the fossa just means hole or ditch, similar to like cranial fossa when it comes to cranial nerves and the exit points in the base of the skull. So fossa in this instance is just referring to a slight ditch you can see when it comes to seeing the scapula, and subscapular just means it's beneath towards the bottom of the scapula. So so moving on to the next part, if we look at the scapula posteriorly now, so posteriorly, the first landmark that you want to look at is the spine of the scapula. The spine of the scapula is the main landmark, which is going to help you differentiate from it being the anterior side or the posterior side of the scapula, because you won't see the spine of the scapula on the anterior side. The spine of the scapula is also referring back to the RESP exams that I was talking about when you ask a patient to lean forward for examining the posterior thoracic cavity when you're doing percussion palpation. You use the spine of the scapula as the landmark for differentiating the different areas you percuss, so that you percuss in sufficient areas to assess all of the different regions of the lung. So the spine of the scapula not only has anatomical relevance, but also has clinical practice relevance. So the spine of the scapula also divides us between the supraspinous and the infraspinous fossa. Now, fossa is going back to the subscapular fossa, cranial fossa, like I mentioned before. But the reason why it's called infraspinous and supraspinous is because it's above or below the spine of the scapula, hence supra or infra. If I'm going too slow, please do tell me, I can pick up the pace, or if I'm going too fast, please tell me, I can slow down. So going, and then here's the acromion again. So now moving on to the lateral view of the scapula. So the scapula laterally, you can see the acromion, the coracoid process, and the glenoid cavity a lot clearer, specifically the glenoid cavity. You can see it present in the anterior view over here, but I'm sure all of you can appreciate that it is a lot clearer from a lateral perspective. So that's why I like to use the same picture but at different perspectives, because you can never ever appreciate all the anatomy from just one cadaveric image or one cadaveric perspective alone. So you have the glenoid cavity over here, the coracoid process, and the acromion, as we mentioned before. Now, I haven't included the medial aspect of viewing the scapula. The reason being, if we viewed the scapula medially, it would just be a straight line. There's not really many, there's no anatomical landmarks to talk about there. And also I couldn't really see any good cadaveric specimens labeled on any anatomy banks out there. So now moving on to the clavicle, another bone which makes up the pectoral girdle. You have two main ends to the clavicle, so the acromial end and the sternal end. Now, this is why I asked in the beginning to differentiate between the manubrium and the acromion, because this is where the acromial end and the sternal end comes from. So the manubrium is part of the sternum, so it's the sternal end because it's towards the sternum. The acromial end is towards the acromion process. Fine, okay. Now moving on to the humerus. The humerus is split into three main regions: the proximal region, the shaft, and the distal region. Now, in terms of the proximal region, one of you did mention this, so very well done. The surgical neck of the femur and the anatomical, the humerus, and the anatomical of the humerus. Does anyone know why each is called which? Any ideas? Yeah, so it's to do with its clinical relevance. So surgical neck is to do with the fact that fracture points are mainly there. It is outside the glenoid well, the glenoid cavity is the actual cavity created by the. So if we go back to this picture of that's the glenoid cavity. The anatomical neck is also outside of the glenoid cavity. So maybe you're getting one or two terms mixed up there. But it's mainly to do with the fracture points. So and then you obviously have the head of the femur. Humerus. And you have the greater and lesser tubercles. Now, tubercle just is referring to a prominence of bone present. And these are important landmarks because it forms a groove. And does anyone know what that groove is called? Intertubercle groove. Yeah. So it's called the intertubular. It can be, but it's also called the radial groove. So the radial groove because of the fact that the radial nerve is passing through there. You also have the deltoid tuberosity, and these are the two main landmarks you need to be aware of when it comes to the shaft of the humerus. Okay, and finally, the last part when it comes to the bones is the distal region of the humerus. And in my opinion, by far, this is probably the most amount of memorization, but we'll try and break it down as much as possible. So let's first of all start with epicondyle. So condyle is referring to a bulb at the end of any bone. An epicondyle is referring to some type of bony protuberance on top of that. Hence the epi part. Epi is just referring to it being on top of that bulb that's ending off that bone. The lateral and the medial is just referring to its position. So the lateral epicondyle is lateral to the in reference to the anatomical position of the body. In terms of what the anatomical position is, just a quick revision of that. So so the arm, if we lay it out flat with our palms facing front and with our palms facing front, the palmar aspect of our hands facing front and the dorsal aspect facing posteriorly, with our hands to the side, that's going to be the anatomical position of the arm. That's where the lateral and the medial aspect is coming into place. Now, the capitulum and the trochlea is referring to the shape more than anything. So capitulum is referring to the fact that it's sort of like a cup for the bone, the ulnar and the radius later down in the forearm to fit into. And the trochlea is just referring to the shape again as well. The Ocranon Fossa, so the fossa part, again, remember, fossa just means a ditch or a small groove. And then the Ocranon part is referring to the actual area. So there's a lot of different tendons referred to when it comes to Ocranon in this area, but that's going to be more covered in the forearm lecture later on, because a lot of this is articulation with the forearm more than actual function in the upper arm. So now moving on to the muscles. Did everyone get everything I've said so far? Would anyone like me to repeat anything? I really don't mind. I'd rather repeat it now so that when we carry on, you guys are all at the same stage. for the clavicle, how do we know left versus right? Okay, that's a very good question. To be honest, it depends on which way around you're looking at it. But let's just go back to a picture of the clavicle real quick. There we go. If you see over here, the acromion end is sort of more tapered, whereas the sternal end is quite a bit thicker. So it's sort of like quite thick towards the sternal end and tapers off towards the acromial end. And that sort of makes sense because the articular surface with the sternum is actually quite a lot greater in terms of surface area compared to the articular surface with the acromial end, because the acromial process is only so large, whereas the sternum is a lot bigger, right? So the easiest way to know left from right is understand which side is the acromial and understand which side is the sternal. And then also the shape towards the sternal to the acromial is sort of going to follow this S shape as well. So this one, if we think about it, all right, in anyone's body, if this is the sternal end, it's gonna, if you flip it around, this one is going to be the right hand side. Does that make sense? Great, perfect. Okay. Any other questions? How to differentiate between anterior and posterior and superior and inferior aspects of the clavicle. Okay, so anterior and posterior, and so to be honest with you, in an exam situation, you're not really going to be asked that. But if you are asked that, the likelihood of them asking that is going to be in a situation where you have everything in situ. So you're not just going to have the bone, because the clavicle is a very weird bone in the sense that apart from understanding acromial and sternal end, you can't really understand most of the other things in it because there aren't that many anatomical landmarks per se when it comes to the clavicle as a bone. Unlike the humerus, where there is things like the greater tubercle, the lesser tubercle, the deltoid tuberosity, the radial groove. There's all, and then you have all the different landmarks when it comes to the distal region. You have the lateral epicondyle, the medial epicondyle, the trochlea, the capitulum, the Ocranon Fossa. You have all these different anatomical and bony landmarks. You don't have that in the clavicle. So it's actually very difficult to differentiate between anterior and posterior. But if you sort of look at this in terms of anterior and posterior, it's more slanted, whereas posteriorly it's a little bit flatter, I'd say. But that's gonna be anatomical variation, depends on the bone. I wouldn't really worry too much about it in terms of an exams perspective or from a clinical practice perspective, because in real life, the only time you're gonna really worry about the clavicle in things like surgery is if you're doing intrathoracic surgery, and you're only gonna worry really about the clavicle so much so if you need to break it in order to get into the chest. Does that answer your question? I know it's a really long tangent to basically say that. Don't worry too much about it. But hopefully the yeah, posterior and superior and inferior, yeah. You're gonna see it more in situ. Once you see it in situ, it should make a lot more sense. So it's like use everything around you to work out which perspective it is. Does that help? Fine. Okay. Are there any more questions? Are there any more questions left? Or shall we move on to the muscles now then? All right, I'm going to take that as a yes to move on to the muscles then. So the muscles part is probably, in my opinion, the part which most can work out, even if they don't know a lot of the textbook knowledge. The reason being, it's the one part which is visually like very easy for everyone to see on their own anatomy. So in terms of the shoulder, so I haven't asked biceps or triceps specifically here because you can work the answer out for both of them just on the name. But does anyone know how many heads there are to the deltoid muscle? And I want the names for every single one of them. You're not wrong with 3. Can I have the names as well? Lateral, medial, posterior. Very good. Well done. Yeah, very good. So, oh no. Maybe do you want to try that again? Because I think if you read through your answer again, you anterior, lateral, and posterior. Yeah. So I get where you're coming from with lateral. Okay, so lateral, medial, and posterior. Let me explain how we can work this out. If you think about it, right, the shoulder is the out, like it's on the outside, it's on the perimeter of your body. So it can't really have a medial head because it's on the perimeter of your body. So if you think about it like boxes effectively on the top of your body, the only sides of the boxes you can actually see visibly muscle wise is the posterior, the lateral, and the anterior aspect. So that's why, and the medial aspect is the articular surface for the shoulders to function. Does that make sense? Intermediate. Could you allow? Okay, great. I'm glad that I answered. I'm glad that you understand that. Could intermediate? Could you expand on that? I'm a little bit confused. What do you mean by that exactly? Is that what one of the names you wanted to say for the heads of the deltoid? Oh, okay. No, so it's no, so the heads of the deltoid are actually a lot less complicated than memorizing any terms. Just it's to do with their anatomical position. So their anterior, their posterior, or their medial is just to do with their anatomical position in relation to the general anatomical position of the human body. Fine. Okay, so yeah, so those are the heads of the deltoid, and just going back some revision. So spine of the scapula. You'll see this constantly during the whole presentation. I will go back to small things we did talk about earlier. So the spine of the scapula, like I said, it's one of those things that not only anatomically is important, clinically it's relevant as well, because it's a really nice landmark from a anatomical perspective for surgery, because once you see the spine of the scapula, you can understand a lot of the different muscles. So for example, the supraspinatus, the teres minor, this teres major, the infraspinatus, you can work out a lot of these muscles just from working out that one anatomical landmark. And the reason being why that anatomical landmark is so nice, it's very prominent in almost everyone. Some anatomical landmarks are not prominent whatsoever, especially on anyone who has a slightly higher than average BMI. It's really hard to see some anatomical landmarks. So the spine of the scapula is one of those few anatomical landmarks once you get into surgery and theaters, you can still see in even those people who have a little bit more subcutaneous fat. So that's why the spine of the scapula is so crucial of a bony landmark to remember. So and then so this is the deltoid. Since we're talking about the supraspinatus, the infraspinatus, we know this is the spine of the scapula. So what side are we looking at? I think the actual slide says the image says it, doesn't it? So if anyone said posterior, they don't get the marks. But okay, so it's not anterior. So it has to be the posterior. because of the fact that, well, it says posterior, but also the spine of the scapula is the only on the posterior side of the scapula. It's not on the anterior side of the scapula. And on the anterior side of the scapula, you won't see any of these muscles. Like the infraspinatus, supraspinatus, teres minor, teres major don't exist on the anterior side of the scapula, only on the posterior side. So that's why it's the posterior. So if we carry on, so the anterior arm. So the anterior arm, we mentioned the deltoid with the anterior head of the deltoid. You also have the biceps brachii. So the biceps brachii can be split into the short head and the long head. Now, the short head and the long head, we're always taught it's because of the fact that one is shorter than the other. I honestly, to this day, still think that the short head is a little bit longer than the long head. So the way, especially when it comes to like cadaveric images like this. So the way I prefer to remember it, just so that I do not mess up when it comes to examinations, trying to decipher which one is longer than the other. L in the long head stands for lateral. So it's the lateral head. And then S is just the other one remaining. So that's another way of remembering it rather than looking at which one's longer than the other, because I'm sure all of you can appreciate that if we actually look at this, they look roughly the same length. And in fact, the short head might actually look even a little bit longer. So that's why I prefer to just learn it as long head is the lateral side of the arm rather than the long head is the longer head of the arm. Okay, of the biceps brachii. Then the other muscles we have is the brachialis and the coracobrachialis. Now the acronym to remember all of these is BBC. So biceps brachii, brachialis, coracobrachialis, and that's going from superficial to deep. That's the easiest way to learn it in terms of understanding their positioning and also just remembering all of them existing, because a lot of people do remember these but then forget these two. So don't forget these two, because these two are often actually what examiners like to bring up because of the fact everyone remembers these. These are like, if you asked a 6-year-old, they can probably point to their biceps. But the coracobrachialis and the brachialis, you probably need to go to med school or have a really in-depth love of anatomy to learn what those two are. So that's why those two, when it comes from an exams perspective, they come up quite a bit. Now, the posterior arm is going to be your triceps. So your biceps, your biceps brachii, your coracobrachialis, and your brachialis are all going to be anteriorly, and then posteriorly is going to be your triceps brachii. So and then you also have your deltoid, so your posterior deltoid, and you can see your teres major here, your teres minor here, your infraspinatus here, and your supraspinatus here. But then going to the triceps brachii, you can see you have the lateral head, you have the long head, and then you have the medial head, which you actually need to go quite deep to actually see the medial head, because as the name suggests, it is medial. So it's quite deep. So yeah, so any questions so far? No. Okay. Fine. All right. Okay, so carrying on. Well, that's all the muscles in the arm. Okay, fine. We'll go into the nerves now. Would Niraj, do we ever give a break during these talks, or so just carry on? Niraj? I think we lost Niraj.
Hi, sorry, my internet. What'd you say?
Do we ever give a break during these talks for the students, or just carry on?
No, it's meant to be an hour, so you just
carry on. Go for it. Cool. All right. Cool. Okay. So we're gonna start with we're gonna go on to the brachial plexus. Now, the brachial plexus is probably the most content heavy part of this section, but I'm going to try and break it down as much as possible, and we're going to try and make it as interactive as possible. So everyone, please do interact with the chat, because you're just going to learn more from doing that. So to begin with, I'm going to just talk through the trunks, a couple of the other divisions when it comes to the brachial plexus, and then we're going to go into the specific nerves, where I've created a couple of questions to increase the amount of interactivity, and so that it registers in your guys' brains a lot better. So in terms of the trunks, so let's start off with the actual nerve roots. So we have C5, C6, C7, C8, and T1. These are the nerve roots that we need to be concerned about when it comes to the brachial plexus. So whenever it comes to exams, and also when it comes to clinical practice, this is the main reason why we do all the weird and wonderful tests we do when it comes to neurological examinations, from reflexes to dermatomes to myotomes. It's to understand if there is any issue with these nerve roots. So, for example, C5, if you have an issue with it, you won't be able to feel something in what we call the regimental area, which is just right next to your shoulder, around about here. So, and then C6 is down a lot lower, around about here. C7 is around here. C8 is here, T1 is here, T2 is up here. So it's important to actually understand why these nerve roots are important, not just for an anatomy spotter exam, also for clinical practice, and also clinical year exams as well. So moving down to the trunks, is made from C5 and C6. The middle trunk is made from C7. And the inferior trunk is made from C8 and T1. Now you can see over here that you have 2 that make up the superior, 2 that make up the inferior, and only 1 that makes up the middle. So there's not really a reason as to why the body is designed this way, but it is an important detail to mention nevertheless, just so that you are aware when it comes to the later divisions we'll talk through in a second. So, and then superior, inferior, and middle trunks, like the name suggests, the superior trunk is the topmost, the middle trunk is the middle, and the inferior trunk is the bottommost. All right. If not, I can repeat it, but if it does, I'll carry on. I know I'm asking a lot, doesn't make sense, but the brachial plexus is something that is probably the hardest thing to wrap your head around. So I would like everyone to understand it properly. So if there are any questions, like if you'd prefer to directly message rather than put it in the chat, just directly message. No questions? Okay, I'm gonna take that as no questions. So let's carry on. So if we move down, we have the divisions. So we have anterior and posterior divisions for all of the different trunks we had earlier. So we had a superior, middle, and inferior trunk before, but then each of them goes into an anterior and posterior division. So you can see here, superior trunk, middle trunk, anterior, posterior division, inferior trunk, posterior, anterior division. And then after that, you have the chords. You have the posterior chord formed by all of the posterior divisions. Now, in my opinion, that's probably the easiest chord to remember, because just remember all of the posterior divisions make up the posterior chord. Okay. And then the lateral chord is made up by the anterior divisions of the superior and middle trunk. And the inferior trunk's anterior division makes up the medial chord. So I would say the easiest way to remember it is remember the posterior chord and remember the medial chord. And then the two left are going to be your lateral chord. So when it comes to anatomy, there are certain things you just have to memorize. Like to this day, a lot, like if you wanted to understand this, this is probably a whole module worth of information in itself. Just understanding why different nerves are mapped the way they are. So understand how to memorize things to minimize the amount of things you do need to memorize. So posterior chord made up by all the posterior divisions. You don't really need to memorize that. Just think posterior divisions. Lateral medial chord is only made up by the inferior anterior division. That you need to memorize. Then the last two anterior divisions from the superior and middle trunk, that's going to be my lateral chord. Does that make sense to everyone? Yes, great. Okay, perfect. All right, so now comes the fun questions that I promised. So, does anyone want to have a go at what the roots of the musculoskeletal nerve are? So roots means refer, yeah. 5, 6. So roots always means that it's referring to the nerve roots. Sorry, I should have been a bit clearer there. So the nerve roots are referring to the 2, 5, 6, 7. Yeah, exactly. So 2, 5, 6, 7. Yeah, so everyone's going on that same line of thought now. So 2, 5, 6, 7. Now, does everyone get how we got there, or would you like me to talk you through it? Again, if you're not comfortable to say talk through it like on the chat for everyone, just personally message me. I'll go through it. I really don't mind. Might you talk through it? Sure, I can. So if you look at here, so obviously in real life you won't see all these nice colors if only anatomy was that easy, but this cadaveric image is quite good at illustrating the different divisions. That's why I used it. So the musculoskeletal nerve you can see over here, and like a couple of you said, that is so the lateral chord is the chord it comes off of, and then the lateral chord, like I mentioned, divisions of the superior and superior and middle trunks. Okay, from that point onwards, you know, superior and middle trunks, the superior trunk receives its nerve roots from C5 and C6, and the middle refers its nerve roots from C7. So that's how you know that it is C5, C6, and C7. Does that make sense? Perfect. Okay, great. Now, great. Okay. So now the motor function of the musculoskeletal nerve, if anyone knows them, muscles of the anterior arm, yeah. Do you want to be more specific? We don't call them biceps in anatomy. It's not deltoid. No, it's not deltoid. Deltoid is another muscle, another nerve that we'll go through in a bit. Biceps brachii, Coracoid brachialis, and brachialis. Yeah, great. Perfect. Yeah. So those are the three. Yeah, don't worry. Zoom does weird things when it comes to the spelling. Also in like exams, so I don't know which universities all of you go to, but in exams, like try and get your spelling as close to as close to the proper anatomical spelling as possible. Like I know some days the anatomical spelling just goes out of your head, but the main thing is when it comes to the exams, the way they usually mark it is the word cannot be mistaken for another word. Okay, so like for example, if you instead of writing coracobrachial, like I can clearly see that says coracobrachialis, but like for example, a D and instead of CH, it would say coracoradialis, which isn't a muscle whatsoever. So it's like that's the main thing. So just be aware, like as long as your term sounds vaguely like what the muscle we're talking about, which it perfectly does, you'll get the mark. So the motor function is all of those muscles. And the way I remember it is the fact that there are 3 nerve roots. So there are 3 muscles being innervated. Okay. It's a very tenuous link, but it does work for quite a few of the brachial plexus nerves, which you will see in a bit. So what are the sensory functions of the musculoskeletal nerve? Does anyone know? So, okay. So, it gives lateral cutaneous branches off the forearm. So it innervates the lateral half of the anterior forearm. So if you think about it, the anterior, whenever it comes to anatomy, always just like resync yourself to normal anatomical position. And normal anatomical position for the arm is palm up, dorsal surface down. So from that point, you need to think, okay, it's the lateral half of the anterior forearm and a small lateral portion of the posterior forearm. So it's almost like half of the arm, but like wrapped around this way. Hopefully you guys can see my arm and like what I'm gesturing. I would get a marker and like shade it, but I don't have a marker. But hopefully you guys understand what I'm trying to say. So, but right, yeah, it is the skin of the forearm. Not so much the anterior arm. It does provide motor innervation, and I guess yes, by virtue, since it provides some motor innervation, it would provide some sensation. But if you think about it, that's not main sensation that we're worried about. And at the end of the day, the main sensation we're worried about, like if you go back to the homunculus with like the nerves and how they're mapped around the body, a majority of the nerve endings are mapped towards the ends of our limbs, right? So that's why we want to be more sensitive over there. So I've only mentioned the lateral cutaneous branch of the forearm, and the anterior forearm and the posterior forearm, but in my reading of it, I didn't find anything when it came to the skin of the anterior arm. can have a second read through it, or if you know of any source provides innovation to the skin of the anterior arm, please do let me know. I will have a look through that, but I couldn't find anything which mentioned the anterior arm. Fine. Okay, so the axillary nerve, again, same set of questions, different nerve. What are the roots of the axillary nerve? Okay. So some of you are just guessing all of them. Okay. So there's a quite a large mix of different answers here. So do you want me to say the correct answer and then talk it through, or just say the correct answer? Wait, which one? Say the correct answer and talk it through? Yes, okay. So the correct answer is C5 and C6. Now the reason being is so the way I always work these out is start from where I'm at in terms of the nerve and then work my way backwards. Because once I get to the trunk, I know my answer. Okay. So that's the point where you want to get back to, because remember your trunks, superior is C5, C6, middle is C7, and then inferior is C8 and T1. So just remember those. So as soon as you walk back to your trunks, you'll be fine. So the axillary nerve, you can see over here, nicely highlighted by this cadaver. You can see it follows onto the posterior cord. And remember, the posterior cord gets the posterior division from every single trunk. But if we follow it back, you can see it actually goes this way to the superior trunk, and the superior trunk is from C5 and C6. Does that make sense? Perfect. Okay, great. Now, motor function. Anyone want to have a shot at that? Yeah, I can explain it again. Sure. Okay. So let me explain it again, and then we'll go through the motor function. So how do you know which posterior division follows if there are three? Okay. Yeah. All right. Is that okay? I don't want to call out names. So is that the same area? So is the question, how do you know which posterior division it follows if there are three? Is that the same query, the person who said, sorry, can you explain again? Is that the same query? Okay, fine. So if we look at this one, in terms of the posterior, when it comes to this, this is one of those things that you actually do have to memorize. So in terms of which one it goes back to, but it's it's similar to what you needed to do for this one in terms of just if you look at this one, once you get back here, it's relatively easy in terms of that one. But this one, what I would say is once we go through the motor functions, it makes a lot more sense as to why it's these two, and also why it's only two. I get where your question's coming from. To be honest, when it comes to this division, I don't think anyone has an answer as to how you understand that it is this one. But if you look at it, actually, these two sort of more merge with this one. and this one sort of more merges with this one, but that's a very tenuous grasp. So it's one of those things, that's why the brachial plexus is one of those things you got to memorize. So that's why I've dedicated like one slide to each nerve to summarize it as best as it possibly can. Okay. What I can try and do is I can try and condense all of the different roots and different motor functions and sensory functions into like a table and send that along with these slides. But does that answer your question for the time being though? Or no? Not really. Okay. Posterior division, if it follows, there are three. So so there are three posterior divisions going into it. I agree with that. But your query is basically, how do we division and not this one or this one, right? Okay. To be honest with you, I don't think anyone knows why. I think everyone just memorizes the fact that it is. Okay. I know that's a really, really bad answer. But I don't think even like anatomy professors would know the answer why. And it's not something that you need to know why. You just need to know to recognize it when it comes to spotters, and also when it comes to real life. You just need to recognize that this nerve's for this. Okay. I'll try and do that table for you guys if that's would be helpful. Yeah. So the motor function, a lot of you did answer. So deltoid muscle and teres minor, yeah. So that is spot on. And teres minor and deltoid muscle. This is why I said the motor function is something that you need to be aware of when it comes to understanding which roots it is. Because remember, as I said, C5 is the sensory innervation for the regimental area of the shoulder. So it's this area. I sort of gave answer to the next question away, but oh well. So if you think about it, the deltoid muscle is also that area. So it provides motor innervation to that. And there's only two nerve roots here. So it only innervates two muscles, being the deltoid muscles and the teres minor. Does that make sense? Okay. Does everyone want to have a go at then answering what the sensory functions of the axillary nerve are? Yeah, regimental badge area. Yeah. Yeah. So it gives off lateral cutaneous nerves of the arm, regimental badge area. It's probably the one like sensory nerve of the brachial plexus that everyone remembers. So because of the fact that it's the axillary nerve, so it's like literally right next to the regimental badge area, and the regimental badge area just sounds really like fancy, so everyone remembers it very easily for some reason. So going on to the next one, the median nerve. So this is probably one of the most important nerves. So does everyone have a go at what the roots of the median nerve are? So there's a variety of answers. So I'm gonna go through it. So the median nerve is a weird one. All of you who said all of them, you're not wrong. And to be honest with you, in an exam, if you said all of them, you'd still get the mark. The reason being why I've just put this little nuance is that some people, only some people have C5 as part of the roots that makes the median nerve. So most people would C6 to T1, but some people do have C5 as well. So it's like, so you're not wrong for saying C5 to T1, but just be aware that it's only some individuals have C5. Now, as far as, so you can see over here, it's C6 to 8 and T1 in terms of this cadaveric image. But if you do any reading online, you'll find out that actually some of the fibers also come from C5 in some individuals. So in terms of the motor functions, does anyone know the motor functions? Most anterior forearm muscles. Yep. So, yeah. So in terms of the anterior forearm muscles, we don't really call them anterior forearm muscles. We like to call muscles usually based on their function. I know I mentioned anterior arm, but that's just that part of the arm. I would call those muscles flexors, and I would call the triceps brachii extensors. So these are flexors exactly. So it innervates most of the flexors in the forearm. The thenar muscles. So the thenar muscles are these muscles in the palm. I don't know if you guys can see my palm, but yeah, if you can tell me. Otherwise, then I'll just put my hand down. If you can't. But those are your thenars, and then your two lateral lumbricals are here. And it's also associated with your index and middle fingers as well. So lateral lumbricals are, your lumbricals are here. So the lateral ones are here. And then there's also some association with these ones as well. Okay. Fine. All right. Fine. Okay. And then the sensory functions of the median nerve, does anyone know? Good. 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 Okay. So it gives palmar cutaneous branch, which innervates the lateral part of the palm. But the main thing that we're worried about in terms of clinical practice or in terms of seeing someone who has median nerve deficit is any issues with the lateral 3.5 digits. So including the thumb, this finger, this finger, this finger, and also half of the ring finger. So exactly. So that's the sensory function of the median nerve. We might run a little bit over. What I can do is I can go through the brachial plexus, I can go through the veins, and then we can send this. Niraj, what do you think about the spotter? What should we do if we're overrunning?
I'd say don't overrun too much. Like if you can't fit it in like 10, 15, 20 minutes and like it's really dragging on, just put it in part 2.
Okay. So I'll try and pick up the pace a little bit maybe. So the radial nerve, the roots of the radial nerve. Does everyone want to have a go for the radial nerve? Yeah. So the radial nerve is all of them. Now, unlike the median nerve, where only C5 is in some individuals, whereas for the radial nerve, it's all individuals, C5 to T1. What's the motor functions? Anyone know? Yeah, exactly. So the radial nerve, the way I remember it is, if you hold your hand like this way, like you're about to shake someone's hand, if you remember, it's all the radius of that. So the radial nerve basically innervates all of that radius. So as the posterior, as a couple of you said, posterior muscles of the upper limb, or otherwise known as extensors of the upper limb. Yeah. So, and yeah, flexocarpi ulnaris. That's like a very nuanced thing, and also one of those things that comes up in exams, surprising amount. Yeah. So yeah, so that's ulnar nerve. Which part? Is the ulnar part of the Sorry, yeah, I misread. It has to be the ulnar nerve, yes, because it says ulnaris inside of it, so it has to be the ulnar nerve. Sorry, I misread the answer right there. So just going back to this, the radial nerve though. So the radial nerve is all the posterior parts of the upper limb. Okay. Does anyone know what the sensory functions of the radial nerve are then? Anyone? Skin, yeah. Yep. Perfect. All right. And the last, but certainly not least nerve of the brachial plexus is the ulnar nerve. So the roots of the ulnar nerve, everyone want to have a go? So the ulnar nerve can't be all of them. So it has to be C7, C8, and T1. The reason being, if we go over here, we can see only the middle and the inferior trunks are the ones that give path to the ulnar nerve. So therefore, only C7 for the middle trunk, C8 and T1 for the inferior trunks are the only nerve roots that can consist to make the ulnar nerve. Does that make sense? Cool. All right. Everyone want to have a go at the motor functions of the ulnar nerve then? The faster anyone answers, the less likely we are to overrun. Yeah. So the muscles of the hand and also the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. So these are, for the ulnar nerve, these are basically like key exam type question areas, I'd say, because of the fact that it's very niche. It's something they can ask, which a lot of people would have forgotten, which is basically best of both worlds for examiners, because they want to test students, but they also want to test students on something that is relevant for clinical practice. And this is something relevant for clinical practice because a lot of people come in with deficits in their flexor carpi ulnaris, and people forget, oh, it's something to do with the ulnar nerve, and I need to look into these nerve roots, and I need to check these dermatomes. So it's actually not only anatomically important for exams and spotters and things like that, but also for real life clinical practice. And then the sensory functions, everyone want to have a go? Faster there's an answer, less likely to overrun. Also, if there are any questions so far, yeah, so it's the anterior and posterior surfaces of the medial 1.5 fingers. So the median nerve was the 3.5. So this is just that 1.5 and the palm area. Okay. So any questions so far though of everything we've gone through with the brachial plexus? Because I know the brachial plexus is something that has a lot of information to digest. Does the median nerve supply all thenar muscles? So thenar muscles is just this muscle. So yeah. So if we just go back to the median nerve slide. So it's the thenar muscles, so it's all of them. The thenar muscles is just the thenar eminence is this eminence over here. Yeah. Does that make sense? Or no? Can you go back to the radial slide for 1 second? I forgot to note down something. Yeah, sure. The radial slide. Let me get all the information up for you. Yeah, if there's anything in the radial slide that you want me to go through again, just tell me. I know you forgot to note down something, but if there's anything you want me to go through again, tell me. If there's anything in any of the brachial plexus stuff so far, before we move on to vascular. Fine. Everyone okay for the brachial plexus now? Then we'll move on to vascular. Yes, perfect. Okay, great. All right, vascular supply. So vascular supply is probably, is it possible to send us all these slides? So I will, Niraj, is it possible to give these slides at the end, or I don't know, like what the whole protocol is? I'd rather Niraj answer that. Niraj?
Repeat the question, sorry.
Is it possible to send them the slides after this?
So typically the way we do things is, so we do recordings up on YouTube and we do slides released after people fill out feedback on Medial. So yes, everything should become available, and then recordings go up. We try to do a week turnaround, but it depends. I just, you know, sometimes it takes a bit longer to edit things and whatnot. But yeah, so you will get everything, all the information, things like that.
Just remember to fill out feedback. All right. So the vascular supply. So this is probably the fastest part of the whole of the lecture. So the arteries. There's only really one big artery you need to be worried about when it comes to the upper part of the upper limb. So the arm, not the forearm. The forearm, there are more arteries, but again, that's going to be covered in the next upper limb tutorial. But in terms of the arm, you have the brachial artery. Now, the first part of the brachial artery and the second part and the third part, the main anatomical landmark that you need to be wary of is the clavicle. So before the clavicle is the first part. After the clavicle is the third part. Under the clavicle is the second part. Okay. That's the only landmark you need to be aware of when it comes to the brachial artery. Now, in terms of all these small different arteries coming off of the brachial artery, to be honest with you, it rarely, I doubt it will come up in any exam, but I put up this diagram nevertheless. What I would say is focus on understanding why everything is called what it is. So if you think about it, for example, let's go through this one, the anterior circumflex humeral artery. It's going anteriorly, so it's going in front of the humerus. Circumflex means going around the humerus. So it's the anterior circumflex humeral artery. Same thing with the posterior circumflex humeral artery. Okay. The subscapular artery is going underneath the scapula, right? The circumflex scapular artery is going around the scapula. The thoracodorsal artery is going towards the chest. So all of these terms make sense. You just need to break them down and think about where the artery is going. Usually, whenever it comes to any of these artery branches, it's always wherever the artery is going towards, that's what the name is referring to. So, and then the next is the veins. So in terms of the veins, you have the basilic vein, you have the cephalic vein, and then you have the median cubital vein. You have these three main veins. All three of them are relevant in terms of anatomy and also daily clinical practice because of venipunctures and cannulas. So venipunctures and cannulas, you're taught median cubital vein, but then you soon realize no one really has a good median cubital vein. So you usually end up actually going for the cephalic or basilic somewhere down here. But again, if you guys are in preclinical, you'll learn that soon enough. And if you guys are in clinical, you probably have learned that already as well. So that is everything regarding all of the teaching. Is there anything that you guys want me to go through before we do the spotters? Anyone? No, fine. So we'll go start the spotter. Great. Okay. Neeraj, could you do a favor for me? Could you just have a timer up for like 3 minutes, let's say, for this slide? If that's possible. I think Neeraj is gone, so I'm just gonna try and do the timer myself. 1 sec. Okay. So
I'm back.
okay, could you just do like a timer for me for like 3 minutes for this question?
Yeah, I got you. Go for it.
Perfect. All right. So everyone, you have actually wait, it's only like I feel 3 minutes. If we keep on doing 3 minutes, each slide is like 2-3 questions, but let's do 1.5 minutes for this each slide. So could you do like a timer for 1 minute 30 seconds actually?
Got you. Yeah.
Perfect. So 1 minute 30 seconds. Tell them when to start. When you started the timer, Nira.
All right, starting in 3, 2, 1, begin.
Don't type in the chat, please. Just write it down somewhere. How much more time left, Niraj?
15 seconds.
15.
Time up.
Cool. All right. So The first one is the acromion. So the reason why I chose this picture is because I feel a lot of students know the cadaveric specimens, but imaging sometimes is a hit or miss. So that's why I wanted to challenge you guys with this. But I feel out of all the imaging, this is probably like the most common type of imaging you would see in day-to-day like clinical practice. So that's why, like in hospital, for example, you would see at least one of these in your medical careers. So 3 is the acromion. So this area is the anatomical neck of the humerus. And as we mentioned before, you have the surgical neck, which is down here, and then the anatomical neck, which is up here. And then this is the scapula. And the reason why you know it's the scapula is actually to do with the shade of gray it is. So if you look at this, this is a much darker gray. So is this, so is this, so is this, so is this, so is this. But this is a much lighter gray. This is a much lighter gray, and this is a much lighter gray as well. And what that tells you is this is bone, this is bone, this is bone, this is muscle, this is muscle, this is muscle. So based off of that, you can tell that this is the scapula, because the only bone that is present behind this and is covered by muscle like this is the scapula. So is 1 minute 30 seconds enough, or is it too long? Should we reduce it to 1 minute now? And any audience answers? Any questions about what the previous one was going through? Nope. Okay. Fine. Should we reduce it to 1 minute instead of 1 minute 30 seconds? Fine. Okay. Niraj, could you change it to 1 minute now instead of 1 minute 30 seconds? Sorry to be bothered.
No, I've already done it. So yeah, if you're ready to go, then 3, 2, 1, begin. Ten seconds. Stop.
Great. Okay. So this we can see that's going to be the posterior head of the deltoid. We know it's posterior because we have all these different muscles that you can only see posteriorly, like the triceps, for example, triceps brachii. You can see the lat dorsi. You can see the teres major. You can see all these different muscles. And then 7 is going to be your infraspinatus muscle. And you know it's the infraspinatus because it's just above the teres minor. Okay. And then the last part is for the teres minor, which you know is innervated by the axillary nerve from the brachial plexus discussion we had earlier. Does that all make sense? Sorry. Does that all make sense? Yes. Perfect. Okay. Great. All right. Fine. So just one very hard one, and then I end off with a much easier one. So in terms of This is a bit harder. So should we still keep it to the 1 minute because it's only 2 questions instead of 3? Keep it to the 1 minute? Yeah, okay. Neeraj, could you start that 1 minute again, please?
Yep.
Thank
Same
you.
again. Yeah. 3, 2, 1, go. Time up.
Time up. Okay. So the first one is for the roots of 7. So if you look at 7, 7 is over here. But if we follow it, you can see that a couple of different nerves actually feed into it. A couple of different divisions feed into it. And also nerve 7, so is going to be our median nerve. The reason why we know it's the median nerve is because of its course downwards, actually. So if we follow it down, you can see that it's following quite middle. So it's median, right? Median, middle. So it's following the middle of the arm. So that's how you know that it's median nerve. And then you don't even need to follow it back after that. So it depends on what type of person you are. Okay. If you have a really good memory, which a lot of people for anatomy sometimes do, and some people just develop it over time after seeing so many cadaveric images and reading so much as well. You just know that, okay, as soon as you see median nerve, you know C6 to T1. But remember also in some people, it can be C5 as well. Some fibers are C5. But that's for that first question for 7. And then the second is 13 for this. So which part of the brachial plexus? So this is why I went through the trunks. First, I went through the roots, then I went through the trunks, then I went through the divisions, then I went through the cords, then I went through the nerves. The reason being, each of these 5 different elements, they can test in a spotter exam. And usually they like to assess the things higher up rather than lower down. The reason being, most people learn the nerves. A lot of people forget about the divisions, the cords, the trunks. So that's why I made it such an important thing to go through that in the very beginning, step by step, rather than just going directly into the nerves. So that's the nerve spotter. And then the last spotter, I'm sure all of you are glad to hear, is vascular supply. So I'm thinking that probably doesn't even need the 1 minute. So shall we change it down to 30 seconds? Niraj, is that all right?
Yeah, go for it. Sure, ready.
Fine. Fine. 30 seconds.
Well, I'll change the timer. So yeah, 3, 2, 1, begin. Time up.
Time up. Okay. So for 9, we can see that it's going to be the cephalic vein. The reason why we know it's the cephalic vein is because the cephalic vein is on the top, and cephalic is referring to anything to do with the head of the neck, and head of the neck of the body is like towards the top of the body. So that's how I remember, like, cephalic vein is, whereas basilic vein is the bottom part of the arm. So that's how I know that's the cephalic vein. And then 8 is our median cubital vein, and the median cubital vein is the vein we're all taught in preclinical and also our clinical skills tutorials on how to do venipunctures with, but then no one actually has a very nice median cubital vein, and if they do, then you are very, very blessed that day. So yeah, so that's all the spotter questions.